talk about diabetes mellitus in pregnancy. Now, these topics are very, very important for obvious reasons. Some of the reasons you're going to be seeing shortly. But besides that, besides the importance for our patients, it's also important for ourselves. The topics are also important for ourselves. You know, as I say, do unto others what you would want others to do to you. So, I mean, if I've looked at this all, it appears to me as if we probably have more women than men, you know, which is, it appears as if that's where we're going in Nigeria now. Even when you go to medical schools, when you go to our hospitals, women far outnumber men. Can you give yourselves a round of applause, women? So nobody can say that we are not empowering women, you know, in Nigeria. So it's, besides for our patients, it's also important for ourselves because, as I said, most of us here are, I mean, many of us here are females. So at some point in our lifetime, we would get pregnant. And for those that are males, you would have partners, wives, that at one point in their lifetime would also be pregnant. So this is quite important. So I'm Abiodun, and I'm with the Federal Medical Center, Abuja. Okay, so I have no disclosures. Okay, I'm going, yeah. So, and this is my outline. As I said, the presentation is going to be into two parts. The first part, cardiovascular disease or heart disease in pregnancy, and then the second part is going to be diabetes mellitus in pregnancy. So for heart disease in pregnancy, what does it mean? So it simply refers to any cardiovascular condition that affects a woman in pregnancy. And cardiovascular diseases in pregnancy, they are the leading cause of maternal mortality. Okay, so I mean, home or abroad, they are the leading cause of maternal mortality. And this is because of the increased prevalence of cardiovascular disease nowadays in women of childbearing age. One, because some women now defer raising families, you know, for professional reasons. Some people have infertility, you know, and then we also have increased incidence of hypertension, of obesity, of diabetes, you know, and because of this, this has led to an increase in the prevalence of cardiovascular disease. And the type of cardiovascular disease you have actually depends on which part of the world you are in. So we know that hypertensive disorders, they are the most frequent. They are the most frequent. And I'm sure that many of us here, we've seen, you know, one pregnant woman or the other or more, you know, with hypertension in pregnancy. But in the Western world, the commonest is congenital heart disease. And the reason for that is because of the improved care of congenital heart disease, such that a lot of these women now live, you know, they now reach reproductive age and are able to get pregnant. Whereas in this part of the world, we're still grappling with rheumatic valvular heart disease. And more importantly, for Nigeria, Nigeria has the highest incidence of peripartum cardiomyopathy in the world. The highest. About 1 in 96 deliveries, and the mortality at a year approaches 50% and more. So you can see that the burden that the cardiovascular diseases impose during pregnancy is quite enormous. And we must take this set of conditions seriously. So generally speaking, heart disease in pregnancy can be pre-existing. So if it's been there before the patient gets pregnant, you say that's pre-existing, okay? But if it is related to the pregnancy, say it develops during pregnancy or the last 5 to 6 months after delivery, you say that is pregnancy related. And we're going to be looking at the spectrum of diseases, the ones that are pre-existing, for example, chronic hypertension, valvular heart disease. You know, I mentioned earlier that rheumatic heart disease is still something with us. I have quite a number of patients like that, young women like that, you know, in my practice. So particularly mitral stenosis and aortic stenosis. There are others, but these two are quite important. Then you have congenital heart diseases, septal defect, tetralogy of Fallot, Eisenmenger syndrome, so that these are things you should watch out for. Arrhythmias, supraventricular tachycardia, atrial fibrillation, pulmonary hypertension, aortic diseases. For example, women who may have Marfan's, So you see, if you see any woman very tall, you know, with very long arm span, you may have to start to think along that line. Or they can be pregnancy related. We've mentioned peripartum cardiomyopathy. We said Nigeria has the highest incidence in the world. Then hypertensive disorders, spontaneous coronary artery dissection, and pulmonary embolism, and the others. So what are the risk factors? Why are women, you know, in pregnancy predisposed to, why do they have heart disease? So we've talked about increasing age at first pregnancy. I said that earlier, probably because for professional reasons or because of infertility. And with increasing age comes, you know, increased incidence in hypertension, in diabetes and obesity. I've talked about improved treatment of congenital heart disease. As I said, lots of women now, they get mitral valve replacement, aortic valve replacement while they are young. And then, of course, they will go ahead to get pregnant. Autoimmune diseases like systemic lupus erythematosus, multiparity, we know from the literature that there's a 16% increase in the incidence of, what does it mean? So it simply refers to any cardiovascular condition that affects a woman in pregnancy. And cardiovascular diseases in pregnancy, they are the leading cause of maternal mortality. Okay, so I mean, home or abroad, they are the leading cause of maternal mortality. And this is because of the increased prevalence of cardiovascular disease nowadays in women of childbearing age. One, because some women now defer raising families, you know, because of for professional reasons. Some people have infertility, you know, and then we also have increased incidence of hypertension, of obesity, of diabetes, you know, and because of this, this has led to an increase in the prevalence of cardiovascular disease. And the type of cardiovascular disease you have actually depends on which part of the world you are in. So we know that hypertensive disorders, they are the most frequent. They are the most frequent. And I'm sure that many of us here, we've seen, you know, one pregnant woman or the other or more, you know, with hypertension in pregnancy. But in the Western world, the commonest is congenital heart disease. And the reason for that is because of the improved care of congenital heart disease, such that a lot of these women now live, you know, they now reach reproductive age and are able to get pregnant. Whereas in this part of the world, we're still grappling with rheumatic valvular heart disease. And more importantly, for Nigeria, Nigeria has the highest incidence of peripartum cardiomyopathy in the world. The highest. About 1 in 96 deliveries, and the mortality at a year approaches 50% and more. So you can see that the burden that the heart, that cardiovascular diseases impose during pregnancy is quite enormous. And we must take this set of conditions seriously. So generally speaking, heart disease in pregnancy can be pre-existing. So if it's been there before the patient gets pregnant, you say that's pre-existing, okay? But if it is related to the pregnancy, say it develops during pregnancy or the last 5 to 6 months after delivery, you say that is pregnancy related. And we're going to be looking at the spectrum of diseases, the ones that are pre-existing, for example, chronic hypertension, valvular heart disease. You know, I mentioned earlier that rheumatic heart disease is still something with us. I have quite a number of patients like that, young women like that, you know, in my practice. So particularly mitral stenosis and aortic stenosis. There are others, but these two are quite important. Then you have congenital heart diseases, septal defect, tetralogy of Fallot, Olugbenga syndrome, so that these are things you should watch out for. Arrhythmias, supraventricular tachycardia, atrial fibrillation, pulmonary hypertension, aortic diseases. For example, women who may have Marfan's. So you see, if you see any woman very tall, you know, with very long arm span, you may have to start to think along that line. Or they can be pregnancy related. We mentioned peripartum cardiomyopathy. We said Nigeria has the highest incidence in the world. Then hypertensive disorders, spontaneous coronary artery dissection, and pulmonary embolism, and the others. So what are the risk factors? Why are women, you know, in pregnancy predisposed to, why do they have heart disease? So we've talked about increasing age at first pregnancy. I said that earlier, probably because for professional reasons or because of infertility. And with increasing age comes, increased incidence in hypertension, in diabetes and obesity. I've talked about improved treatment of congenital heart disease. As I said, lots of women now, they get mitral valve replacement, aortic valve replacement while they are young. And then, of course, they will go ahead to get pregnant. Autoimmune diseases like systemic lupus erythematosus, multiparity. We know from the literature that there's a 16% increase in the incidence of cardiovascular disease in multiparous women. Then we also have assisted reproductive technology, usually because of ovarian hyperstimulation syndrome. So these are some of the risk factors that can predispose women in pregnancy, to heart diseases. So what about pathophysiology? What happens? What are the hemodynamic changes in pregnancy? So there are changes in pregnancy, of course, it's obvious, that, of course, when you see a pregnant woman, aside from even before the uterus, starts to show, there are changes that start very, very early on, starting from the first trimester. And these are changes that are for women who have, whose cardiac reserve are okay. There's no problem, they can cope. They may have some symptoms, which we're going to talk about later, but generally they'll be able to cope. The problem arises when there's a background heart disease. Say the cardiac reserve, is impaired, is compromised. So typically, the most important thing is that you have an increase in plasma volume starting from the first trimester, as well as a 10 to 15 beat per minute increase in the heart rate. When you put those two together, you have a 30 to 50% increase in cardiac output. At the same time, you have a reduction in systemic vascular resistance, and that can cause blood pressure to be reduced by about 10 to 15 millimeters of mercury. So, as I said, usually most people are able to cope with this, without issues. But if you have a bad heart, say for example now somebody has mitral stenosis. In mitral stenosis, the mitral valve is narrowed. That means the left ventricle filling is impaired. So you can imagine somebody who is now pregnant with mitral stenosis, and you're having large volume of blood in the left atrium that is unable to pass into the left ventricle. What happens? Of course, cardiac output is reduced, the baby will suffer, no nutrients, no blood, no oxygen, and then it would cause an increase in the left atrial pressure. And with that, there's a backflow into the lungs, patients may have pulmonary edema. With pulmonary edema or heart failure, you have hypoxemia, right? So the woman suffers, the baby suffers. You can also look at another example, say Olugbenga syndrome, for example. So in Olugbenga syndrome, you are saying that somebody has a septal defect, and and when you have a septal defect, say a VSD, typically you have a left to right shunt. Blood moves from the left ventricle, say a VSD now, to the right ventricle. But over time, patient may develop Olugbenga syndrome, in which blood will now move from the right side to the left side. Now, when that happens, with so much blood, because of increased plasma volume, you have deoxygenated blood, large volumes of deoxygenated blood moving to the systemic circulation. That will worsen hypoxemia for the mother and as well as for the baby. So these are the things that are responsible for the changes that you see in normal pregnancy, as well as, so 3 important things: increased cardiac output, reduction in blood pressure, increased heart rate. Okay, so most patients are able to tolerate this without any problem. So these physiological changes, the reason why they are important is because at times they can mimic heart disease. So somebody may come to you, obviously I'm sure we've seen pregnant women with leg swelling. Isn't that so? So you see, and you begin to wonder, in local parlance, in our settings, in fact I saw somebody today or yesterday came because of leg swelling, which is a good thing because we're beginning to have lots of awareness. So when people have leg swelling, say, doctor, are you sure I don't have heart failure? So you may see a woman with leg swelling, which is one of the symptoms of heart failure, which Dr. Taiwo discussed about the other time. So and you may feel that, okay, is this heart failure? What's going on? Or is this a feature of normal pregnancy? Now, it's the reason why what Prof said the other time, taking good history, examining your patient, very, very important. So you must learn to take history. Oftentimes, in most of our GOPDs, our private settings, people just scribble chest pain and then examine and then go and do something. No, we must always learn to take a good history and examine our patients. And when you take a good history, if somebody tells you that they are dyspneic, a pregnant woman, she's dyspneic, she has autopnea, she has PND, she has palpitations, she has chest pain, you should take that seriously. Those are not normal symptoms of normal what? Pregnancy. So you should take that seriously. But if a woman comes, my legs are swollen, of course, you should take history, you should examine to be sure that these other sinister symptoms are not there or signs are not there, before you say you can go, there's no problem. Examination, very, very important. So you should look out for pathological murmurs. I understand that when we were in medical school, I remember those days, we say, okay, the professor will say, yeah, come and listen. Can you hear it? Everybody will say, yes, I can hear it, when you can't hear it. So I know that a lot of us have experienced that. So, these days, the beauty for our generation these days is that a lot of these things are on YouTube. Do you understand? You can go on YouTube, go and brush, examination up. So if a patient has, a woman has diastolic murmur, has a continuous murmur, or has a systolic murmur with a trill, these are pathological murmurs. They are pathological murmurs, and you have to do something about that. And what will you do? Before I go on, just to, of course, we've talked about NYHA class certification. We talked about Dr. Taiwo and Dr. Isoko talked about that the last time. Very, very important. I said class 1, no limitation of symptoms. Class 2, limitation of symptoms on moderate exertion. Limitation on mild for class 3, and then when the patient is sitting at rest like this and is having difficulty breathing, that's class 4. So when your patients come, pregnant woman says, I am breathless, you must find the class, because this tells you the severity of the symptom. It's very, very important. So what should you do? If you suspect that a woman has a heart disease, she's dyspneic, she has palpitations, she has chest pain, the thing to do is to send for help, refer the patient. So you can refer the patient to Cardiocare. You can call Dr. Isoko. He will be more than happy, to listen to you. So because, and I'm going to give you some stories, because if you don't do that, most likely the outcome will be very, very poor, for the patient. So we must always learn when we suspect heart disease in pregnancy that we get help. We refer to the specialist. So the specialist will do one of many things, of course, for those patients who have heart disease before getting pregnant. So there are some heart diseases that patients can have and they can get pregnant. And there are some heart diseases that they can have that they must never get pregnant. Oftentimes in my practice, the women, my patients with peripartum cardiomyopathy, I will tell them, when you are coming next, bring your husband, because we must talk. Because you must not get pregnant, at least for a period of time. So there are certain cardiac diseases that patients may have, and they can get pregnant. And that's why you need to send to the specialist so that they can do a pre-pregnancy counseling for them. And they're also going to assess their risk, their maternal risk. We're going to see how to do that shortly. And the specialist is also going to do certain tests, ECG, echo, exercise testing, and many other important tests, which a general practitioner, cannot do. And this is the instrument for assessing cardiovascular risk. It's the Modified World Health Organization classification. So you can see from class 1 to class 4. So somebody who has a PDA, patent ductus arteriosus, or has a corrected ESD or VSD, their risk, the cardiac risk is low. They can get pregnant again. But somebody who has, is in class 3, EF, ejection fraction, we talked about that the other time, is 30 to 45%, you know, or somebody who has peripartum cardiomyopathy, without resolution of the cardiac impairment, the left ventricular impairment, they can't get pregnant. That would put them in class 3. Or somebody who is in class 4. Those ones in class 4 should not even get pregnant at all. They should not think about it. And that's why when you have a patient who has heart disease, you must send to the specialist. So somebody who has pulmonary hypertension, or ejection fraction is less than 30, or has previous peripartum cardiomyopathy that is unresolved, or severe mitral aortic stenosis. These are patients that you don't want them to get pregnant. So you can see for this fourth class, the maternal cardiac event rate is about 40 to 100%. That's very high. Okay? So counseling is important for all of them. All of them should have their care in the hospital. You can see how to follow them up, and all of them must be managed by a specialist. And in fact, it's not just enough to manage by the specialist in some cases. For those with in class 3 and class 4, they should be managed in a center with a pregnancy heart team. And that brings me to one of the points that Dr. Taiwo was trying to make. For heart failure, even in the general population, we know from the literature that patients who are managed by heart failure patients that are managed by heart failure specialists, they do better than heart failure patients that are managed by ordinary cardiologists. So you can imagine, even if heart failure patients do better with heart failure specialists, you know, they are cardiologists though, the two are cardiologists. One is not a heart failure specialist. One is heart failure specialist. Patients do better with heart failure specialists, not to now talk of a general practitioner. Do you understand? So when you see this patient, you suspect heart failure, get help, refer them. You know, one of the important things I want you to take away is recognition, because that's one of the biggest problems. If you don't recognize that somebody is in heart failure, will you be able to refer them? No, it's not possible. Will you be able to refer them? No. So identification is important. But as soon as you identify, you must get help. So, and it's for this reason that, you know, the management of heart disease in pregnancy, it's what we call, using what we call cardio-obstetrics model, the heart pregnancy team. So if someone has heart disease before getting pregnant, you know, the care is planned from before conception till after delivery into postpartum period. Very, very important. So when to refer, I've said that, you know, anybody who has any of these diseases, heart failure, valvular disease, stroke, PE, even diabetes mellitus, uncontrolled hypertension, you know, you must get help for such patients. So quickly, just to look at some of, you know, 1 or 2 disorders, or heart diseases in pregnancy. Hypertension is important because it's the most frequent. And I'm sure that a lot of you will be seeing lots of patients with hypertension in pregnancy. So we know that if blood pressure is persistently above 140, persistently 140/90 and above, that's hypertension. We've established that. It is severe in pregnancy if it is 160/110 and above, and it becomes an emergency if it is 170/110 and above. So you can see the different types of hypertension in pregnancy. It can be chronic, that's if the hypertension has been there before pregnancy or before 24 weeks. Gestational hypertension, there are 2 types. That's high blood pressure hypertension after 24 weeks. So if there's protein in the urine, then it becomes what? What does it become? Preeclampsia. It becomes preeclampsia. Otherwise, it's just ordinary hypertension. And you can have the 2, you know, chronic hypertension with superimposed gestational hypertension. So how do you manage hypertension in pregnancy? If it is non-severe, the first-line medications are oral labetalol, alpha-methyl-dopa, and extended-release nifedipine. Okay, so, and what you want to do is just to make the blood pressure, the target blood pressure should be below 140/90. But if it is severe high blood pressure, hypertension in pregnancy, or it's an emergency, you must get help. I'm sure if you call Dr. Iseko, he's not going to say no. If you call Dr. Taiwo, you know, I mean, nobody, they're not going to be angry with you. They're going to be, so you must get help for severe hypertension in pregnant because it's an obstetric emergency. So for the residents, they know it's important for them, because in emergencies, you want to use intravenous medications, and over 2 to 3 hours, you just want to gently lower the blood pressure, because if you do that rapidly, of course, you can cause cardiogenic shock, acute kidney failure, acute MI, all sorts of problems. So that's one of the reasons why once you see this patient, you get immediate help. And then very importantly, like I always tell my people the gynecologists, the obstetricians in my hospital, it's not every patient every pregnant woman with severe hypertension that you give labetalol. If you have pulmonary edema with severe hypertension and you give labetalol, you are going to kill that patient. So it's important that you always get help when you have patients with severe hypertension in pregnancy or hypertension, or you have hypertensive emergency. So for heart failure, very, very important, these are things that can cause heart failure in pregnancy: hypertension, peripartum cardiomyopathy, and the likes. We've talked a lot about heart failure. The important thing to take home is that you must, when you suspect somebody has heart failure, please get help, refer the patient. Some time back, a general practitioner, for example, saw a patient with heart failure, and just placed on. He did well, even made the diagnosis, recognized it, did echo, ejection fraction was maybe 30, but placed on furosemide and sent the patient home, didn't refer the patient. It was a patient on her own through one of her relations who is also a specialist registrar that now, this is not right now. Why? Because even though you may not be able to give the same drugs, in pregnancy with heart failure as you would in the general population. Do you understand? But there are certain medications, neurohormonal medications that Dr. Taiwo mentioned that you can use in pregnancy or in the postpartum period. So, and it's only the specialists, that can do this safely, do you understand? And safely for the patient. Because if you don't do that, the beauty about peripartum cardiomyopathy is that there are four things that can cause reversible heart failure. Heart failure is a bad disease. The prognosis is even worse than cancer. You've had Dr. Eseko mentioning 50%, 80%, very bad. It's a terror. That's the word he used. So you don't want somebody who has peripartum cardiomyopathy that can be reversed. Do you understand? To now become a permanent thing, an irreversible thing. And that's why when you suspect it, you must refer. There are 4 things generally for the residents, that can cause reversible heart failure. Peripartum cardiomyopathy is one of them. Alcoholic cardiomyopathy is another. That's why anybody who has heart failure, they can never drink alcohol again. Otherwise, that heart will never recover. Then, of course, tachycardia-induced cardiomyopathy as well as Takotsubo syndrome. Okay, that's for the resident. So it's important because there are medications you can give in pregnancy for heart failure. There are those that you can give, and the same thing applies for the postpartum period. So please, when you suspect, please refer such patient. Now, a lot of patients with heart disease in pregnancy, they either have native valvular disease or prosthetic valves. And this is one of the reasons why you must refer when you suspect. So that somebody who has mitral stenosis now, severe mitral stenosis, that person can get pregnant. But that person, if you send to the specialist, can get mitral valve replacement, after which she can then get pregnant. But if you don't do that and the patient gets pregnant, the outcome is going to be very poor. So this is very, very important. Some of the women, they also have prosthetic valves. A couple of my patients, I have lots of patients, young women, prosthetic valves, they've got pregnant without issues, but there can also be issues. Like, I remember an example, young woman had mitral valve replacement some years prior. She got pregnant, and because of that, when you're in a prosthetic valve, you have to be on anticoagulation, you have to be on warfarin. But you can't use warfarin when you are pregnant. Especially weeks 6 to 12 and after 36 weeks. But generally, for safety, most physicians, cardiologists just say, just be on heparin. So I placed this woman on heparin. I placed her on Clexane 40-12 hourly. But because of cost, she went home and she was using 40 once a day. Of course, understandably, she came to the emergency with stroke. But thank God, she recovered within 3 days and went back home, and she had an uneventful pregnancy. So for patients who have prosthetic valves, they need to be managed by the specialist. Now, these are the other conditions that can also predispose to stroke in them. The other important one is even pulmonary embolism. And I'm going to cite 2 examples, to drive home my point. I remember one of my patients, she was pregnant. She hadn't seen me for a while. She was going out. She wanted to cross a culvert. Then she fell. She now had a fracture. So unfortunately for her, she went to see a general practitioner in town, a private hospital. So that one, according to him, said he wanted to put on Clexane, but my patient refused, that she wasn't sure it was compatible with what? With her pregnancy. So weeks later now, she was brought to our emergency in FMC, with pulmonary embolism, and she died. So it's important. Don't keep these patients. Somebody has had disease, you are suspecting it. Don't keep them. I would have been able to convince her that Clexane is the way to go, heparin is the way to go, and it will not harm your baby. So when you are not when you see patients like that, have disease, please get help, for them. It's very, very important. And it can even happen to doctors. I have another case, a doctor, asthmatic, got pregnant, IVF pregnancy, multiple gestation. Noticed that she was getting breathless. Felt that it was her asthma. Kept taking Ventolin. Until one day she went to the toilet, she slumped and she died. It was at autopsy. The husband was already fretting. Called the father-in-law that, am I not in trouble? Don't worry, we're going to do autopsy. They did autopsy. It was pulmonary embolism that killed her. So these symptoms, when you see symptoms, cardiovascular symptoms, as I've said, dyspnea, palpitations, chest pain, orthopnea, PND, please get help for such patients. So patients can also have atrial fibrillation and SVTs during pregnancy. So you see somebody in pregnancy complaining of palpitations, you do ECG, so you have to do ECG. That's the first thing. You do ECG and you are getting 120, 130, just refer that patient. Do you understand? So that the cardiologist can sort them out. For the benefit of the senior residents, of course, one thing I want them to take home is that DC cardioversion is safe, in pregnant women in which is indicated. So somebody has atrial fibrillation now, she's pregnant, and blood pressure is 70/40. You're not going to say that because she's pregnant, I'm not going to DC cardiovert. You go ahead and do that. It is safe. There's no problem. Then coronary artery disease, acute coronary syndrome. These are things that can happen in pregnancy. We've said that, women with increasing age are getting pregnant now, and then the type of MI that they can have in pregnancy is different from the general population. They call it spontaneous coronary artery dissection. So the treatment is the same generally as MI in the general population. So the lesson is that somebody is complaining of chest pain. Don't say it's PUDO. Oftentimes, we get that, Dr. Seko, all the time. They say it's ulcer. But when you get into the cath lab, 100% occlusion of the LAD. So when you get patients like that, you can send them to Cardiocare for help. So I've said pulmonary hypertension, Olugbenga, and some others are cardiac conditions in pregnancy that you don't want to get pregnant. They should not get pregnant. So for myself now, in my practice, for my peripartal cardiomyopathy patients, I sit them down. Say, go and call your husband. I tell them, you can't get pregnant for at least 3 years. So after 3 years, we'll now decide whether you can get pregnant or not. And fortunately, most of my patients who present early with peripartal cardiomyopathy, after 3 years, with resolution of left ventricular impairment, they go on to get pregnant and deliver without any problem. So it's always good to put that at the back of our mind. So I'm rounding up. So for delivery, vaginal delivery, except for obstetric reasons when you want to do CS. So briefly, let me talk about hyperglycemia in pregnancy. Is glucose intolerance of variable degree with first recognition or onset during pregnancy. There are two types. So hyperglycemia in pregnancy can either be pre-gestational, before 24 weeks, or gestational diabetes after 24 weeks. And it's important because it's associated with adverse outcomes. For the child, twofold increase of serious injury at birth because of macrosomia or shoulder dystocia, fourfold increase of NICU admissions because of acute respiratory distress syndrome, prematurity, hypoglycemia, hypocalcemia. They can have congenital anomalies. For the mother, threefold increased risk of cesarean delivery. They can have hypertensive disorders, pulmonary embolism. And the pathophysiological basis is that the placenta, produces a lot of hormones. You can see them, human placenta, lactogen, estrogen, progesterone, and the likes that cause insulin resistance. And with insulin resistance, you can have hyperglycemia. And what do? So the way to screen them, some people believe in universal screening. They screen all their women. We don't do that in Nigeria. According to EMSIN, that's the Endocrine and Metabolism Society of Nigeria. So what they do is targeted screening. So you identify those patients, those pregnant women at risk. So if someone is above 30 years, has had GDM before, has family history of diabetes, has a previous macrosomic baby, bad obstetric history, has polycystic ovarian syndrome, hypertension, or you see glucose in their urine, or they are obese, overweight, or have macrosomic babies in the index pregnancy, or polyhydramnios. So they are the people you want to screen. And what you do is that you give them a 75-gram oral glucose load, and if you have any of these abnormal values, fasting above 92 or more, 1 hour, 180 or more, 2 hours, 153 or more, you say they have gestational diabetes mellitus. So, and what do? You refer them. That's the thing. They should be managed by the endocrinologist. Is that so? So, for those who are diabetic before pregnancy, they can give them pre-pregnancy counseling. Or for those who have GDM, you must send them to the endocrinologist. They must see. Okay? So for anybody who is diabetic before pregnancy, as soon as they get pregnant, antenatal care must start. Unlike normal pregnancy. Is it second trimester they start it? When do we start antenatal care? Is it first or second? First, okay. So, but for diabetic women in pregnancy, as soon as they get pregnant, you start antenatal care. And insulin is the first line for treating GDM or pre-GDM. Okay, some people use metformin, glibenclamide. Those ones are second line, but EMSIN, they recommended insulin, because we do not have safety data for metformin and glibenclamide. So, and it's one of the reasons again that you must refer them to the specialist. So you want to ensure that their glucose is controlled. You give them monthly visits, depending on the trimester. If they have macrosomic babies or other obstetric complications, you have to schedule them for elective CS. And more importantly, at 12 to 6 weeks postpartum, you have to do another OGTT. Why? Because more than 50% of patients with GDM will develop type 2 diabetes within 5 to 10 years. Do you understand? Afterwards. So you must do an OGTT 6 to 12 weeks postpartum for any persistent glucose abnormalities. So in summary, if someone has heart disease in pregnancy, they must have pre-pregnancy counseling. So you send them to a specialist to see them. The same thing applies, for diabetes. So one of the things I want you to take home is ability to recognize heart disease in pregnancy, When you say somebody has dyspnea, somebody has autopnea, these symptoms, please get them help. You can refer them to Cardiocare. Somebody has glucose abnormalities in pregnancy, you should refer them to see a specialist. Thank you, everybody. So are there questions, or we are not taking questions? Questions? Yeah, appears it was well understood. Thank you. Thank you, everybody. There's a question at the back. Let's take that, please.
Thank you very much, sir. My name is Chijoke Otipa. I am a physiotherapist. And from everything you've said, I've been asking myself, because a lot of times we get involved with pregnant women during the antenatals. Not a lot of times, but sometimes. During antenatals, supervising and prescribing, coordinating antenatal exercises. And I've been kind of curious how we can be integrated in this, particularly around cardiovascular issues in pregnant women, how we can be integrated in. I looked and saw that the team, the multidisciplinary management, there was no physiotherapy there. So I think it would be nice to kind of make us aware of certain things, as physios. So I was asking, where do we come in, particularly because we're also very much involved with these women? Thank you very much.
Thank you for the question. It's a brilliant one. Let me just say that it was an omission. I copied that slide from somewhere, so I couldn't have added physiotherapy to it. So, but you indeed have a lot of role to play. Don't forget that in our disease, that the physiotherapists have a role in rehabilitation. There is a whole field of cardiac rehabilitation. And of course, this will go a long way, in helping your patients with symptoms, with exercise tolerance, and so forth. So you indeed have a role. And it's one of the reasons why patients like this must be sent to the specialist, so that the patient can be seen by a multidisciplinary team. Of course, that includes people in medical rehabilitation. Thank you.
One more question, sir.
Okay, yeah.
Thank you, sir, for your presentation. My name is Dr. Ahmad Usman. I'm a senior registrar in cardiology from Odu Sokoto. Mine is a comment. In as much as these patients are referred regularly to high centers, there is also need for the high centers to feed back to the referring physician as much as possible, because some of these patients, after referring them, you will not see them again till after when patient is developing heart failure again. So I want to call on to the management that they should, the managing physician, to also look at the two-way referral system, which is going to go a long way in managing this patient. By the time they go back home, they will still come back. For example, patient that has PCI, coronary intervention, they will be on their medication, but they will still come to us for follow-ups. Patient that had ICD, implantation, CRT, and the rest of them. So I want to still emphasize that, please, we need that two-way referral system to be active. Thank you.
It's okay, thank you, the SR from Odut. So, of course, that's important. One of the take-home messages here is that when you see someone who has a disease in pregnancy or diabetes, please send to a specialist. When the specialist is done with the patient, the specialist can decide, whether the patient can, go back to, typically, patients should be able to go back to the general physician, for example, but at the same time, still maintain follow-up, with their specialist. So, thank you, sir. There's a question here. Thank you, sir, for your presentation. Please, what's your view on bromocriptine in PPCM? So, if I recollect very well, I think it's class 2A, or 2B. So, it's not really a first line. I mean, if you want to use it, it's fine. I don't do that in my practice, and I get results. I use just a class 1, guideline recommend drugs, medications, and I get results. But I know that I think, if I recollect very well now, I think it's class 2A, so it has a place, and it certainly can be used. So thank you, everybody, and have a wonderful afternoon.